Hi, Dr. Lee. Yes, please, practitioner, please give us 1 more minute and we will start the session. Thank you. Hi, Dr. Ang. Hi, Dr. Yang. Hi, Dr. Lim. It's now 7:30 and 8:30 at other country in Asia. So I think I saw many people logging in at this time. So I'm asking to give them about 3 minutes to have a more people to join, and then we can start the session. Thank you. All right, just 1 more minute and we should be able to begin the session. Thank you. Hi, Dr. Chan. All right, Ms. Dom, I think we can start now.
Yes, okay. So welcome on the doctor, optometrist, and practitioner to join our webinar today. Our topic today is introduce, reviews, and certifies IC, Paragon Crt, and Lateral. This webinar is brought to you by Autocad Vietnam Limited Company. We are the distributor of GP Specialist, one of the world's largest selections of AutoCAD design. We offer expertise and technical support for all designs, including IC, Paragon Crt, and Lateral. I'm honored to welcome our speaker today, Dr. Liberty Hải Hồ Nguyễn, who is the orthocatalogist consultant from GP Specialist and Paragon Vision Science Certified Trainer. Before we start, I will read some notes to the audience. During the webinar, if you have any questions or concerns, please use the Q&A functions. It's the round and triangle icons on screen at the right bottom. We will collect all the questions, and the last 30 minutes is for the discussions part. In this training sections, we will record it to ensure the quality of this webinar. We will mute on the audience. The participant can raise hands or send message to us for further support. Thank you so much, Dr. Liberty Hải Hồ Nguyễn, for your time today. Now the audience is on yours.
Thank you, Tom, and my deepest thanks to all practitioners, ophthalmic healthcare provider, and also all attendants today for the lecture of introducing, reviewing, and certify IC Paragon CRT. And we also talk a little bit about Apical Stigmatism for the myopic, hyperopic, and presbyopia treatment. So let me share the screen. Ms. Tom, could you please share my screen?
Yeah, we are viewing your screen now. So
right. Thanks, Ms. Tom. Okay, so can you see my screen now very well?
Yeah, we do.
Okay, so welcome again. We are mostly talking about the Firewall LAN, IC LAN, Paragon CRT LAN, and some technology in iBring Pro fitting. Let me introduce myself again. I'm Dr. Nguyen, and I am a certified trainer for GD Specialist and Paragon CRT. Both belong to Cooper Vision. The content today is quite a lot. So it will be a review for some practitioner, but it also have some new information for practitioner who start the AutoCAD treatment. So we have 8 lectures. Lecture 1 is about introduction in AutoCAD that most people know. Lecture 2 will be IC LAN design and comparison, the design with other designs. Lecture 3 will be the help you to effectively select the initial LAN based on keratometry, and based on topography will be a huge difference between the information that you gather, so you can get a better initial selection with the topographer information. Lecture 4 will show you and introduce you how to fitting the eyesight and iBring lateral LAN. Lecture 5 will be Firewall and IC troubleshooting. Lecture 6 we will talk about LAN care and maintenance. Lecture 7 will be Paragon CRT design and troubleshooting it. It's also a good section for us to actually review with troubleshooting of the Firewall LAN and the IC LAN. And lecture 8 will be showing the practitioner how to effectively troubleshooting and design AutoCAD LAN using the Medmon topography. So what is AutoCAD? Most practitioners know, so this is a very beginning information for those who start looking into AutoCAD treatment. So AutoCAD is actually a rich LAN that's used to molding the cornea using the tear film between the LAN and the cornea and the hydraulic negative force from the reverse zone and the positive force from the alignment curve in order to molding the cornea to the structure similar to the inside of the AutoCAD LAN. And this morphology is very much the calculated morphology that bring the vision into nearly planar. So the history of AutoCAD, I just skip the information, just go into the 2020 FDA approved the first AutoCAD design Paragon CRT and Firewall LAN, and also the material Paragon XDS for the night-wear AutoCAD contact lens. And this is one of the GD specialist lab in 12 years ago. So how Autocad work, and this information is for the patient for who actually looking into Autocad treatment. Before the myopic eye is as most people know, and then after the treatment, we have Autocad molding the cornea and bring in the morphology of flattening the central cornea and bring the cell and its liquid to the peripheral and provide the flat cornea and able to focus the light on the retina. And the video will show you how Paragon CRT actually molding the cornea after 8 to 6 hours. We show the video to tell you that the reverse zone is very important area in this method, and we want to focus on safety in Autocad. And later lecture you will see most of the important zone that many people does not pay attention is the reverse zone while treating the Autocad. So providing Autocad treatment, we should know very well lens description and compare the design of the lens. I will show you clearly on the next slides. The material of the Autocad, as most people know, it is fluorosilicon acrylate polymer with 1% of water. We are fitting Autocad about 90 to 95% of the cornea, and we possibly can fit up to 80% to 89%. It depends on the myopic and it depends on the cylinder. If you have a very high myopic, high cylinder, we need a larger lens, approximately to 89%. But if you can fit the Autocad with 80% and the visual acuity is stable, it's the best. So the small lens but well fitting is better than the bigger lens. And FDA only approved the Autocad for 60 dk to 100 dk. It have not yet to approve the material for the Autocad under or above this dk. I believe because if you go over 100 dk, maybe the lens is too fragile, or you have to change into hyperopic material, and it become very soft, and it should it should prevent the tear flow with the soft lens. I believe that is why possibility for FDA only approve the dk for 60 to 100 dk. And I will skip this to show you the reason why Autocad control myopic, because you can see Wallace and Crt research, and they indicate that when patient wearing the conventional GB lens is called peripheral defocus, and this defocus causing elongation of the actual lens. And when we use the Autocad, it will help the light to focus correctly on the central and peripheral. And because of that, the Autocad eyes after 2 years wearing could be able to reduce the actual elongation into 0.2 plus or minus 12 millimeter. Meanwhile, the conventional GB increased the actual elongation into 0.11 plus or minus 0.11 millimeter. But this is the study back to 2010. According to Mark Cosgrove and many practitioners, we have a clinical observation that up to 80 or 90% of the patient come back to exchange the lens after 1 year or many years with the same RX. That means up to 80 or 90% of the patient could keep the eye to be stable and reduce the reduction of myopic. Theory and mechanism, we show that Link found that neither endothelium density change nor the morphology change over the 6 years. So the Autocad was concluded to be a safety use. Compared to LASIK surgery, the AutoCAD is good because of its reversible condition. We can see the video and see when we release the lens within 24 hours to 72 hours, the corneal power back. And because of that, it's very good technology to stop progressive myopic for the children. And it will be a big help to surgery to also giving the AutoCAD treatment for the children when they are young, and when they get older, they can stop the AutoCAD if they don't want AutoCAD anymore, and if they qualify for LASIK surgery, they can do it later. So the AutoCAD actually assisting surgery to surgeon to have a very good and safety treatment for the patient, and have the patient with worse treatment with the low myopic. And my first lecture might be boring to practitioner who know AutoCAD, but please wait for the other 7 lecture. We have to able to present the patient that the difference between the soft lens and the hard lens. The hard lens, AutoCAD lens, is actually it's very safety because it have the design with a very good tear film, and this core a very good prevention for dryness for the patient at nighttime if we fit correctly. And because of that, my fitting AutoCAD is very much focused on the reverse zone, not the base curve, not the alignment curve, but centration with good reverse zone is what we actually focus on. And AutoCAD is safety to be wear at nighttime. Secondly, the second lecture might cost your attention. I will share the difference between the design of IC, Firewall, Paragon, CRT, and all the design. So I will skip this information to go into the original Firewall design in 2002. In 2002, we have the AutoCAD design as Firewall, and many other designs are very simple. It have most likely 4 portions: the base curve, the reverse zone, the alignment curve, and the peripheral zone. The Firewall lens was upgraded into 2003 to 2011. We increased another alignment curve, is the second alignment curve. And the second alignment curve right here next to the reverse zone, it helps to push back the cell and the liquid into the central cornea. To do so, we have the central cornea to be thicker, and we molding the central cornea. We should be able to keep the central cornea flat, but still thick, and it's safety for correction of high myopic. Similar Firewall in 2012 was upgrade to the IC lens, and we see right here we change the IC lens with a very thin tier between the first and the second alignment curve. This thin tier is very important. It provides the tier channel to be provided equally on the lens, and it helps to provide more tier to exchange under the lens. More importantly, in 2012, we increased the peripheral to 0.6 millimeter, and because of that, we continue to supply more tier and evenly divide on the cornea, and it happy for high myopic treatment for the IC lens. So when we turn the design on the sideway, we will see that we have a deep area even between the first alignment curve and the second alignment curve. We distribute the 60% on the top and 40% on the first alignment curve right here. So we helping to bring more cell from the alignment area of the lens or outside of the optic zone, inside the optic zone. Why the IC lens is safe? Because first we can have the dispensing set of AutoCAD IC lens with 5.8 to 6 millimeter, make smaller treatment zone if needed in order to treat hyperopic patient. We have the second alignment curve. We have a better tear exchange as I show you in previous slide. We fitting the IC lens on K1. The K1 fitting is very effectively because it is safety. K1 is the vertical, horizontal K, and it just touching the lens. And because of that, it doesn't compress too much power on the cornea at all. And if we have a high cylinder, we will use premium lens, toric lens, or atrium toric lens to divide the force effect on the central cornea and other area very equally. And because of the effectiveness of the IC lens for positive 4 and negative 4 equally, it's very safety for high myopic treatment. And I copy the slide from Dr. Kuchima, and this is his own eye. For 10 days, we can see the 10 diopter was almost plano for his OD, and OS only 1 diopter left. So it's very effectively treatment for high myopic and high cylinder. I would like to show you the difference between the Paragon CRT design and other design, especially IC and Firewall design. Paragon is proximity design, and it reduce the height in order to compress on the cornea. We can see the positive 4 right here. And then with Paragon CRT, it was able to provide a very thick and nice reverse zone, which is reduced, provide a very good negative 4 in order to treat the low myopic, below 6 diopter or lower, with a very nice and light force. So Paragon CRT take a little bit longer to bring the patient to plano, but it's very safe and very comfortable. And the thickness, central thickness of the Paragon CRT lens is only 1.89 millimeter compared to 2.4 millimeter to the most Autocad lens. So Autocad with treatment Autocad with Paragon CRT is the most safety treatment for most practitioners under to looking for treatment under 6 diopter or lower. And more than that, we can use off-label and other designs. Depend on the FDA of your country. Some allow higher off-label, otherwise other country did not. So you have to look into the FDA approval of your country too. Well, and this section we will show you the difference between the fluorescein pattern. And looking into the fluorescein pattern, you can see a different structure of the lens, and it's very interesting for you to see this structure and choose the best lens for your practitioner. For example, you can see the Firewall lens here, very simple. You see the IC lens here with tear were distributed very evenly all over the lens, and with its safety for high myopic treatment. You can see Paragon CRT here with very good and nice returning zone depth and very nice base curve, very thin alignment curve, and a good landing zone angle. So because of the different design, Paragon CRT is a graded design for low myopic. IC is graded design for high myopic treatment, and Firewall is the design that you can use between them. Then on the right hand side, we have a hyperopic design and presbyopia design. We will see that we contribute the 4 on this design on the inner and outer of the alignment of the reverse zone right here. And we create the negative 4 on the central cornea. So we steeping the cornea at around 4 millimeter with hyperopic lens. And we're steeping the central cornea with about 2 millimeter with the presbyopic lens. And then we steep on the central cornea and we flat lens slowly to about 6 millimeter close to the reverse zone. So to doing so, we can convert the eye into multifocal eyes. And the other design on the market, we have many design, but for practitioners who use the Autocad treatment for the long-term use for the patient, please focus on the tear under the lens, which is very important. If the lens centration, assuming the lens given the same amount of visual acuity at 20/20, then this lens is the best because it provides a very good tear exchange under the lens for the healthy of the cornea. Why Firewall and ISIS lens is very effective to be used. Before we only have a standard lens and toric lens. Then later we have a premium lens, and 2021 we have extreme toric lens. This is my pattern in 2020. And this is the pattern for high cylinder treatment. So if any lens design above 1.75 cylinder treatment, it belongs to my pattern. And again, why we have a different type of lens on one design. We have a standard lens, a spherical lens. We have an IC toric lens, is the dual axis lens. This lens is available before 2016. In 2016, I designed a premium lens, and the premium lens for the IC is actually very effectively designed. And why it effectively? The premium lens is the low toricity lens, and it helps to centration the lens. If the delta K would mean K1 minus K2 over 75 diopter. And the premium lens is also toric lens with the side chain form 10.2 on the top of the lens chart and to 11.4 on the bottom of the chart. On the top of the chart is a very stiff eye, and stiff eye we have a small diameter. On the bottom of the chart is a very flat eye. A flat eye we have a bigger diameter. So the premium lens is very good, effective lens in consider of the size and the centration. And because of that, IC lens, you have a very effectively tool to fitting the cornea accordingly to its toricity. Then 2021, 2020 to 2021, I and my colleagues also have the pattern in extreme toric lens. Extreme toric lens is actually the toric lens with with the same amount of cylinder with the toricity, but we correct the reverse zone and alignment curve 1 in order to have the lens centration better. And GB specialist lens, we also have a hyperopic lens and presbyopic lens, as I showed in previous lecture. The characteristics of ideal fitting the Autocad lens. First, we have to check the lens code. Make sure we wear the correct lens on the patient's eye, and patient not mixing up between left and right. We check the lens diameter is about 90 to 95% of the cornea. This is perfect fit for the Autocad lens. The central application is about 4 millimeter or more. It should have a narrow 1 or 2 millimeter of the reverse zone tear. And then wide alignment curve about 3 to 4 millimeter. We have it lift to exchange the tear, and if you see a very good eclipse like this one, it's actually very safety for the cornea. And when when you examine patient eye on the slit lamp, and you have to ask the patient blink, and the lens should be moving about 1 millimeter. That means the lens is not too tight and it's not too loose. When we over refraction the lens, it should be close to 20/20 visual acuity. If we use the correct lens. If we use a spherical lens to correct both spherical and also stigmatism, you will not see 20/20 visual over the lens, but it will be okay as long as your treatment final result giving a good visual acuity. And as I mentioned, for long-term use in autokeratology, practitioner, please focus on the fluorescein thickness. We should create a very good fluorescein pattern like this. It's not because it's the good ideal fitting, but it's also a good amount of tear under the lens for the safety of the cornea. And ideal is not always we have this number. Ideal, we should have about 5 micrometer of tear all over the lens. We should have a clearance area about 85 micrometer and similar to the peripheral of 85% of 85 micrometer of tear. So the above is good fitting. You will see a very good tear channel all over the lens. The below here is incorrect fitting, and you will see a very insufficient tear film. So if you see a very insufficient tear film like this, even the visual acuity is 20/20, you have to refit the lens in order to provide more tear for the cornea, because this is very unhealthy for the cornea for a long-term use. Well, lecture 3, I will help you how to select the Firewall lens, the IC lens using keratometer and keratometry and topography. There are a difference between them. For example, if you don't have a topographer, you might be able to correct Autocad, but you should be correct the Autocad with low myopic. And we can use the delta K in order to select the lens effectively. For example, if we have a delta K, which means K1 minus K2, lower than 1 diopter of cylinder, then we should use standard lens. If we have a delta K 0.75 to 1.75 diopter, we should use the premium lens. And if we have a delta K over 1.5 diopter, we should use the toric lens. So that is before the topographer, or if you don't have a topographer. But if you have a topographer, you can also use delta K above with the topographer picture, and you can picture or morphology of the cylinder to select the lens better, or you can use the micrometer system. So if you have lower than 30 micrometer, you can use standard lens. 30 to 60 micrometer, you can use premium lens. 60 to 90, use the toric lens, and above 90 micrometer, you can use toric design or extreme toric design. And if you have a topographer, you can select the initial lens more effectively by using the axial map, tangential map, refractive map, elevation map, and subtractive map. For example, this is the information you only have for keratometry. And we have K1 is 42.2, K1 is 43.3. Assuming this is 1 diopter, we can select the first lens. And then we decide to choose standard lens or the premium lens or toric lens based on delta K. So if we're looking for this information, we will see the delta K here is 1.3 diopter. We should use the premium lens. And the delta K over here is 0.9 diopter. We should use the standard lens. And if we use the premium lens on this eye, standard lens on this eye, and then we we insert the fluorescein on the eye and we troubleshoot it. But most likely 80% we choose incorrect the initial lens. When we have a topographer, for example, in this situation, even we have a delta K is 1.3 diopter, but it's central cylinder. It within the 6 diameter position because one box is 1 millimeter. So if you see only 6 millimeter diameter like this, and the alignment curve out here is at 8 millimeter, this eye doesn't need the premium lens or toric lens to centration the eyes. It only needs the standard lens. So when you have the topographer, you can choose the initial lens more effectively, and it saves your time to exchange the lens. Similar, if you see into this eye, even you have a delta K only 0.9, but because the toricity extends to the peripheral of the cornea, then you should use the premium lens or the lens with low toricity in order to centration the eyes, the lens on the eyes. Another case right here, we will see apical stigmatism and then limbus to limbus stigmatism. Apical stigmatism right here, you can see the lens well centration, even it does not provide a very nice optic zone. If you wait for a couple of weeks, the optic zone will slowly form and nicely form. And if it doesn't nicely form, you can change this lens into premium lens with low toricity in order to have the lens fitting the cornea better. However, the same spherical lens, if you apply it on the limbus to limbus eyes, you will see a channel of tear on the 6 and 12 o'clock, which means even the entire system of the cornea right here is dipping out, but the toricity part is lower. And if you look into the lower or deeper, if you look into the elevation map, you will see negative number right here. That means it's deeper area on the eyes. And because it's deeper, you will see the channel of tear over here. And this spherical lens should not be able to well centration on the lens or provide a stable visual. And because of that, you have to change this lens into toricity lens. So what is toricity lens or dual access lens look like? It looks like exactly the picture you see here. So we will design the returning zone or alignment curve over here steeper and deeper. So it will lock onto the toricity area right here and right here. So you can see right here on the Paragon CRT, they provide a deeper returning zone depth right here on the returning zone depth right here and on the below inferior bottom of the lens. So to do so, when patient blinking the eyes, the lens is stable and then centration itself onto its area. And with the topographer, you can, it will help you to see all the morphology of the cornea, and from those morphology, you can choose the initial lens more effectively. I borrowed the slide from Dr. Sinjab in Simjab Academy 2018. This morphology show you how to select the patient for surgery. However, this morphology is very effectively help you how to select the initial lens effectively too. For example, if you have a symmetric shape, and the first picture show you a round shape within 6 millimeter of the length of the cornea. And we know that alignment curve length is about 8 millimeter out here. It doesn't affect by the cylinder or stigmatism of the cornea. Because of that, we only need the standard lens in this case to correct the both myopic and cylinder. The second picture shows you the oval morphology. So if this one is about 7 millimeter or less, you still can use the standard lens. But if oval extend above 7 millimeter, that means half of the alignment curve, then you definitely need the premium lens in order to centration the lens. And if you see a symmetric bow tie like this, definitely you need the toric design. And then we also have cornea stigmatism with a symmetric shape. We have a superior and inferior stigmatism. Then with this morphology, you might only need the standard lens if it's under 1 diopter. But if it's above 1 diopter, you need the premium lens in order to centration the lens. You might not use the toric lens because toric lens with too much stigmatism will stuck right here and will stuck right here in this case, and it won't be able to centration either. It needs the premium lens with low toricity. Similar, if you have a asymmetric shape of the toricity, which is asymmetric bow tie superior stiff and asymmetric bow tie inferior stiff, you definitely need a premium lens in order to centration this cornea. And more complicated, if you see a symmetric bow tie skew or asymmetric bow tie skew, this picture right here, you might need the premium lens or the toric lens to centration the eye. If you intended to customize this lens, please use the dispensing set lens first. Try to find and fitting on the cornea a couple of weeks. Make sure it's well centration before you customize the lens if you are far away from the lab. If you are far away from the lab and you provide a very first customize for this one, most likely it will be the centration on the lateral. Either one side of the eye will be lateral decentration. With very big morphology of the stigmatism, it will decentration on this side, and if very thin one, it will be centration on the opposite side. And because of that, you really need customized sets or the dispensing set before you do the customized lens for this patient more effectively. And if you will topographer good enough, you will it will help you very much to eliminate the contraindicator for Autocad lens. So this is good toricity for the Autocad. This is keratoconus most likely, and this is the contraindicator for the Autocad treatment. And most likely you have to have other corneal thickness to see the local thinner of the cornea. You see the elevation map where it's higher on the front, and the back also higher on the back. So this is keratoconus, and you see the different contribute on the curvature of the entire lens, entire cornea, and this is very much keratoconus, and you cannot use the Autocad contact lens or surgery, but you have to use the scleral lens for this patient. If you use the Masmon topographer, they have other disease indicator, with the scale lens 10 diopter. That means the difference between the most stiff and most flat over 10, eccentricity over 0.8, IS value inferior and superior. The difference between 3 millimeter on the bottom and the 3 millimeter superior, different of 1.3 diopter. Or the surface asymmetric index over 1, surface irregular index over 0.8. So all of the indicator is the determine a possibility for keratoconus, and you have to use the scleral lens for this patient. Well, the scleral lens, even if bigger, the soft lens and the RGB or the Autocad lens, it's very effectively for not only keratoconus, it can use for irregular cornea with very high cylinder, with a very high myopic. It can use for a treatment for dry eye, both LASIK surgery complication, pollucis, marginal degeneration, corneal ectasia, and also keratoplasty patient. So it have a very huge amount of scleral candidate for the scleral lens. Why is that? Because the scleral lens, we can produce a very nice and thick tier between the cornea and the lens, and because of that, it can bring the light to focus better on the retina. And for some keratoconus that cannot be corrected by all the lens, it well corrected with the scleral lens. And the scleral design is very actually simple. It have a base curve. It have a limbus zone, which is a most important area to release the touching between the cornea and the sclera. Then it have a sclera or the alignment zone, which is very much second important to prevent the impingement or prevent very high pressure on the scleral area where it's landing the lens. Well, fitting the eyesight scleral lens, you have to make sure that we don't have any blanching here or 360 degree of the lens. Very nice and a gentle touch on the alignment curve of the lens. We should see a very good tear on all over the cornea, and there's no touching on the central cornea along with the limbus zone between the cornea and the sclera. The way to choose the scleral lens is very simple. You calculate the delta K. If the delta K is below 5 diopter, then we only need to take the flash K plus 2 to select the initial lens. If the delta K, which is K1 minus K2 over 5 diopter, then you take the average K plus 1 diopter to choose the initial lens from our initial power right here. And then we wear the lens for the patient. We examine the central clearance, limbus, lyran, and then also the light touch on the alignment curve of the scleral lens. And then lastly, we over refraction the scleral lens and give us all of the information along with the topographer and the exam information. We will design the scleral lens for you. So this part I already described it to you. You can read more detail at home. Then the scleral lens with eye bring is another level of scleral that we can able to perform the templates of our own eye and duplicates the morphology of the eye without the need of other information. And we should have a scleral lens very lightly touch on the cornea 360, and it's very effectively for most of the cornea. And the process only take about 3 to 4 minutes. It takes 1 minute, about 40 seconds to set up, 20 seconds to place the compound on the eye, and then 2 or 3 minutes waiting for the compound to dry and remove it. And the next video, you should have ability to see it.
10 more seconds to go. Dr. Hyde, ready to go.
So why they say we're ready to go, because we have to wait for 20 seconds for the compound to stable before we able to insert the templates.
At the heart.
So we have to tell the patient to look straight forward at a position and don't move the eye. We heard beep beep because that is the time the compound is ready, start to be dry, and we should not touch the lens anymore or the templates anymore.
10 more seconds to go.
And now we can see how we remove the lens after 3 to 4 minutes.
It dries. So it's no longer tacky is the term.
No longer sticky, tacky.
Yeah, sticky tacky. So it does pretty quick. We're just about there. Touch it now.
All right,
See
better.
the difference?
Mhm.
Okay.
And you don't want it
We
to
can
be too dry, right? It can
no, we don't want it to. We do not want to take it out too soon. We
exactly.
can
But
leave it in longer, but we don't want to take it out too soon.
how about you don't want to put it in too long too, right?
Nah. Well, usually just because people can't see.
Okay,
All
now
right,
we
come
can
out, we relax.
relax,
Break the section.
break the section and remove it out. See, we have a very nice
Wow, nice.
copy of our morphology,
Perfect.
both
You were a very good student.
cornea and sclera.
Nice. Look at my eyes. What's going on?
Well,
Well,
over there.
yeah, it's a little bit irregular.
So I have a little bit irregular with tuberculum, and because of that, it's the best prescription more for my eye is iPring Pro scleral lens if I need scleral lens, and I actually have a one. It wears so comfortable on the eyes, and you don't feel it. Even soft lens you can feel it, but for the scleral lens, when we do it correctly, we won't be able to feel the lens on the eye.
To take it out, tells it.
And I am also the certified practitioner for the iPring fitting. So the contraindicator for the AutoCAD treatment, I will skip it and you can read it at home. We will go to lecture 5, how to troubleshooting the firewall and the IC AutoCAD lens. Well, most practitioners know to troubleshooting the AutoCAD lens. So with most practitioners, it's a review for you. With other new practitioners, you can learn how to select the initial lens and troubleshooting it. For example, if we have a patient come to -2 diopter and K1 is 45, then we will select the G9 lens and is the initial lens for that patient. It might be the final lens too. It depends on how our selection correct or incorrect on the morphology of the stigmatism of the patient's eye. So for example, this patient after 2 weeks, 1 or 2 weeks, and it's over responding. That means somehow my eye is well responding, and I have to use the lens less power. So right now, even my eye is -2 K45, it's over responding. So I have to use the lens with less central flatness. So I will have to stiff the central cornea right here, half diopter, and reduce the lens to -1.5 diopter in order to provide treatment with -2 diopter. So when it's over responding, you only need to move the lens to the left half diopter. So what we do when we move the lens to the left, we actually only release the base curve right here or the treatment zone right here, less stiff. Less flat half diopter and more stiff. And the reverse zone is changing accordingly. We keep the alignment curve of the lens still the same. That is why it's still number 45, and peripheral still the same. Some practitioners will allow the patient to wear every other day if they have only half diopter over responding and they have a 20/20 vision in the evening. The other case is over responding, under responding. When it's under responding, that means I do wear my G9 lens, it's correct with my RX, but somehow next 2 weeks, I still have a remain of half diopter under correct. So I will increase, practitioner will increase half diopter on the lens. So now I will use -2.5 to correct -2 diopter. So when we do show, we will change the base curve right here of the -2.5 lens is more flatter. It half diopter flatter and stronger in the central cornea. Reverse zone will change accordingly, and the alignment curve will stay the same. Peripheral stay the same. So remember, when we move the lens to the left, from the left to the right of the chart, selecting chart, we actually increase the power and increase the flattening or touching on the central cornea. When we move the land from the bottom to from the top to the bottom, we actually flatter the alignment curve of the land. We make it flatter. So another case, if the land is steeping or the land is actually high rider. The land high rider when it is too flat compared to the cornea. So if the land is too flat compared to the cornea, we have to choose the land more steeper. So this case, we will exchange the G9 to G7. So in this case, we will keep the base curve the same, reverse zone the same, but we make the alignment curve more stiff, half diopter more stiff. And another troubleshooting is to moving the land down, half diopter. When you see vaulting, and how do you consider the land vaulting? The first thing is you can see the land vaulting if the land have a lot of tear under the base curve, under alignment curve, and all over the land. That means the land is too steep compared to the cornea. So to make the land fit the cornea well, we have to flat the alignment curve. So that's why we use the land half diopter flatter in order to troubleshoot the steeping land. Another way we can recognize a steeping land over here when we see a lot of forest seen on the reverse zone, and we don't see a very round and nice base curve. We see more liquid, more fluid and tear on the 6 and 12 o'clock. That means it also vaulting, and this vaulting is also because of the high cylinder. That's called the vaulting. So the land have a less cylinder compared to the cornea. So this case we can flat the land or we can increase the toricity for the land or both. Another case, vaulting land. If you see in this case, the two land are also vaulting. But this land is vaulting and it have a very nice diameter. It's about 95% fit of the cornea. So we see a lot of tear on the reverse zone right here and also bubbling. So the land definitely too stiff and you have to flat the land half diopter in order to make a centration. However, if you see the land on the middle right here, it's also steeping and you see a lot of bubbling over here. And this land, it possibly because it's too steep, but it's also the main reason for the land to show the steeping land because it's too big on the cornea. It covers 100% or more than 100% of the cornea. So in order to troubleshoot this land, we have to make a smaller lens and the entire land will drop down. So we have to find the problem with the vaulting land correctly in order to troubleshoot it effectively. And most of the vaulting land you see will show central island. And another interesting way to troubleshooting the land is to change the land to enough toricity. For example, we see the land right here before changing the land. It looked like the land vaulting and decentration, but it's actually not. This land able to form a nice alignment curve. However, if you see 6 and 8 o'clock, 6 and 12 o'clock, you see a channel of tear. This means a lot of toricity right here is not correct effectively. And you have to move the land from standard land to premium land or toric land in order to have it well centration. And this is the real case we can see when we move from spherical land to toric land, it's well centration. And then we also have another problem with decentration is lateral decentration. And lateral decentration, there's many reasons that's called lateral decentration. The first reason because the land we choose is less toricity compared to the cornea. So we have to increase the toricity on the land like this case in order to make the land well centration. The second problem with the lateral decentration is the land too big or the land too small. So if this is the case, you move the lens to the center of the cornea and see the size of the lens on the cornea. It's better than you measure on the topographer. And then you can definitely see the lens too big or too small. And the last reason of the lens that's called lateral decentration is the first K that you choose incorrectly. If you choose first K incorrectly, it's also called vaulting and lateral decentration because it's stuck on the vertical meridian of the eyes. So, well, let me review to you how to troubleshooting the firewall and IC lens. Very easy to remember. If you need more power, you move lens to the right, and you need less power, you move lens to the left. When you do so, you only change the base curve of the lens. If the lens stiffen up, you move the lens up, which means you make the lens more stiff. If you see the lens moving down and vaulting, then you flat the lens. But if you see the lens moving down and a lot of tear channel on 6 and 12 o'clock, then you have to change to the torus design. And if you see the lens lateral decentration, remember there is 3 reasons for lateral decentration, and you have to find the correct reason in order to troubleshoot it more effectively. And here is the summary of good fitting, superior, superior decentration, inferior decentration. And how do you see if superior decentration, the lens is too flat compared to the cornea? You can see the lens too flat, so it only touching on the steep part of the cornea, and it open the other portion of the lens because it's too flat. And this, the lens is too steep. It causes a lot of vaulting on the portion part of the lens. This is the topographer from Kojima to review for you. Good fitting, smiling face, superior decentration to stiff lens, central island, slant too big, too small, or too vaulting. Brownie face, the lens is inferior decentration because it doesn't have enough toricity or because it's vaulting. So we have to find the good problem in order to troubleshooting it. Laser mark on the AutoCAD firewall and IC lens is very important because we know if we fitting a correct lens on the eye. And we also know if the laser mark is also reflect correction. For example, H16 is only 2.5 diopter, 2.25. SI6 is actually 7 minus 7 diopter. So we have to review the laser mark on the treatment of the autokeratology before we troubleshooting the lens. Well, if we have a MedMon topographer and we are setting the measurement at 8 millimeter core, then we also can use the eccentricity to choose the initial lens more effectively. Depend on the lens design, and some lens design give you the eccentricity, other lens design did not give you eccentricity correctly. So you hardly can use the eccentricity to select the initial lens. But luckily, the IC lens provide you the eccentricity of the lens is 0.4. So if the eccentricity of the patient is 0.5, you flat the lens half diopter. And if the eccentricity of the patient is 0.3, so it's smaller than 1.1, then you steep the lens half diopter. And well, this is the example of the good centration lens, and this is the real time of the IC lens. First, you can see a very good tear between the alignment curve. That distribute a very nice tear film for the lens, entire lens. And you see very nice reverse zone. You see nice movement, nice peripheral. And the good fitting when the eye open wide, it should be, the lens should be centration itself. So you already choose a correct alignment curve 1 of the lens that equivalent to K1 of the cornea. And look at this lens. It's very, if you have fitting a patient with this lens, you don't have to worry. Lens movement very well, is smaller than the cornea, very good tear film on the central cornea, good tear film even between the alignment curve. It's very safety for the patient, and it should provide a very good correction. Well, IC Customize is professional control. You can control base curve, reverse zone, alignment curve, optic zone, overall diameter, peripheral zone, and also color. So that is why whenever you need a customized IC lens, you can correct all of these value and just provide us the number that you order, and we can do it for you. So okay, we go through the IC and Firewall summary. So now we go to lecture 6, which is lens care and maintenance. I did not distribute a visor in any Asia country except Vietnam, but I using this product for over 10 years, and it's very good product to be used. So I refer this to practitioner, and for Autocad contact lens, it have a very good reverse zone right here. And because deep reverse zone, it's better to use GB multi because it can manually clean very goodly when you man a very big defect and any residue on the lens by hand. So you can use multi GB for cleaning the lens. Other solution you can do is you can use to clean the lens is hydrogen peroxide with 3%. Everclean Plus, it also have a lipic and protein remover. It really helps to remove a very fine small part that stick on the lens compared to the GB multi. So it's very good for you to use the Everclean Plus 2. So patient can choose one of the two. And patients who are more careful with the cleaning and lens care, they can use both product. So they use GB multi one day and then switch to Everclean Plus another day. And that is the best to clean the Autocad and disinfection the Autocad lens for the Autocad user. Well, and the lubricate on the Autocad lens is very important because if you use too much viscosity, it will trap on the reverse zone and it reduce the correction of the corneal correction on the lens. And if it's too thin, it will it produce more friction between lens and eye. So Glass Reflect Comfort is the best that we use for 10 years, and it's very effectively for the Autocad patient. For the long-term use, we can use the Unido without the reservative or reservative-free, which is very good for the patient for long-term use. And remember that the Autocad eyes is the healthy eye. We should not use a long-term use for any dry eye drop for the lens. We just use the regular tear, especially the regular eye drop without reservative. Is this one. Well, anything with non-reservative is the best for the Autocad. And likely a couple years later, a visor have a glass reflect cleaning. It adding polyhexamide 0.001%. We have to clean the lens while patient is wearing the lens at night. So this eye drop is actually very good, not only for Autocad lens, but any RGB lens or any soft lens should be used this eye drop for using the lens together with the eye drop. So after the lens care, I would like to go to lecture 7 of Paragon CRT troubleshooting and its designs. Well, as we know, Paragon CRT is a most safety design that we have globally. Why is it safety? Because it's very gentle, reduce the height of the base curve, reduce the height of the alignment curve, or reverse zone, returning zone depth in order to provide touching on the cornea slightly and gently. Then it can open the landing zone angle in order to provide more tear or reduce the tear to have the centration. Secondly, the design have a very big optic zone and very large returning zone depth, which also help to provide a very good tear under the lens. And the thickness of the Paragon CRT lens is only 1.89 millimeter compared to 2.4 millimeter is other designs. So a very good lens design for low myopic, especially under 6 myopic. Very much like IC lens, but the Paragon CRT lens use the first number as a base curve, and every 0.1 millimeter is considered equivalent to half diopter increase. And the returning zone depth, or this one we call reverse zone on IC, is used to troubleshooting the Paragon CRT. And every increase of 25 micrometer is steeping the lens half diopter. It's very much equivalent to the troubleshooting of the IC lens with the alignment curve, but it uses the returning zone depth. And then the Paragon CRT also have the landing zone angle, which we can open or close the angle to have centration the lens or provide more tear for the lens. So it's very effectively designed for AutoCAD treatment. And for practitioners who use IC lens before, you can use Paragon CRT with a simple troubleshooting is to use the base curve and the landing zone angle. The base curve similar to the base curve of IC, landing zone angle, landing zone revert. The landing zone is also the extra used for the Paragon CRT, and the returning zone depth is actually equivalent to the alignment curve of the IC lens in troubleshooting the lens. Well, because the Paragon CRT is the lens that is very effectively in terms of one lens can provide many prescription for your patient. For example, if you have the lens 8-0-5-5-0-34 angle, you can prescribe for curvature of 44.75, and patient have a minus 175 diopter, use this lens. The same lens can be applied for the patient at minus 3 diopter, 3.25 diopter with the K1 is 46.25. So one Paragon CRT lens can have up to 1 to 12 prescription for the patient. And it's very useful for the practitioner who want to have the dispensing set on their facility. Paragon CRT is the best. And because of that, I want to Firewall 1 Paragon CRT is similar with the way we choose the, we select the lens on the IC. So we give you the lens chart right here. You can have the diopter across, and we have vertical as the K1. So from K1 and from the diopter, you can select the lens just like the IC lens. So it looks very easy. And because the ability of one Paragon CRT lens can have up to 12 or 13 prescription, 90 lens Paragon CRT, you can cover 100% of the patient come to facility, have a lens to dispensing, is to you immediately, or maybe fitting with very close, nearly correctly before the final customized lens. And for 49 lens is already certified. 85% of the patient port come to your facility with lens on the eyes. 33 lens can certify about 70% of the patient come to your facility with correct lens on the eye when they go home. Why I refer practitioner to use the dispensing set, especially Paragon CRT set, because when you use a dispensing set, you should be able to troubleshooting the lens immediately. So if you have the lens decentration, you have the lens that incorrect power, you can fix it immediately. If you are customize the lens, especially if you are too far from the lab, and you customize the lens, it takes too long for the lens to arrive. If your first customize is incorrect, the patient end up to wear incorrect lens for a long time before waiting the correct lens to arrive. Because of that, I advise practitioner to use dispensing set to troubleshoot the lens and to fit in for the patient and refill the dispensing set. And you don't have to get a very big dispensing set, only 33 lens or 49 lens is good enough. According to Nguyen and other college working with him, they are looking into 56 eye for 2 years. Compare between dispensing set user and customized lens user. We found a very interesting information that practitioner who use the dispensing set to fitting the lens and fit in before customized lens improve the therapeutic duration 4 times faster. For example, if you see the dispensing set here, you see about 6 or 7 days, they can improve the, they can plano the eye. With the customized lens, it takes up to 30 days because the customized lens takes too long and because the problem between fitting the first customized lens and waiting for the second customized lens come if the first customized lens is incorrect. To do so, if you do the customized lens, I suggest to use the lens from the dispensing set first. And when you are getting the lens very good centration, you're able to correct about 20/80, then you customize the lens. And that's where you can get a better correction on your therapeutic treatment for the patient. Well, and if you use a customized lens, we see that practitioner who use the dispensing set improve the frequency of exchanging lens. Over here, we see the dispensing set user did not change the lens for a lot of cases. And there's more exchange lens with the customized lens for those who use the customized lens. And because of that, the practitioner who use dispensing set prior customized lens improved the therapeutic visual 20/20 better than the empirical order. And this is not always right. This is right for the market far away from the lab. Come back to the Paragon CRT. So this is the 136 lens Paragon CRT can cover huge amount of patient for the practitioner. So how Paragon CRT work? This video is actually good for your patient to understand the myopic and how the contact lens work. It's not for practitioner, but you can view and you can use for your clients, for your client consultant. All right, and next slide, I will show you how the proximity control work on Paragon CRT. So this is the base curve, and you can change the base curve 0.1 diopter. When you move, you increase 0.1 diopter flatter. This means the lens moving down. So we can see this. You see the base curve more flatter. When we increase 0.1 diopter for each step. And every 0.1 diopter, you see the lens will become more flatter on the central cornea. And every 0.1 millimeter equivalent to half diopter increasing. And over here, we can see the different when we reduce the reverse zone depth. When we lower reverse zone depth, is similar as we flatter the alignment curve of the IC length. But every unit of reverse zone depth or RZD in the Paragon CRT is half diopter flatter. And the superior design of the Autocad contact lens with Paragon CRT is that you can open the landing zone angle. The smaller number, the bigger tear exchange for the lens. So because they calculate the superior surface of the angle, so the superior smaller, the inferior is bigger, and because of that, the small angle provide bigger open. The next sections, we will show you how to troubleshooting Paragon CRT. It's very much similar or exactly like IC lens, but it's different just because we choose the different way to changing the units on the lens. For example, if this one is called slightly vaulting, lens is well centration, it's just slightly vaulting on the cornea. So if we see this on the IC lens, what do? We move lens to the right. That means we increase half diopter stiffen. That means we increase this area half diopter stiff. Half diopter flatter. And the same thing with Paragon CRT. We will choose this number from 8.8 to 8.9, which is half diopter flatter on the central cornea. So very much similar between Paragon CRT and IC lens, but it's just different unit to be used. Well, we might also able to move the lens down if the lens show a little bit faulting and it's also show a little bit stiffing. So in this case, with Firewall, we can move lens down half diopter. With Paragon CRT, move lens down half diopter mean we reduce the returning zone depth by 25 micrometer. But because the lens well centration, the best to do in this case is to increase the base curve by half diopter for CRT lens or even for the IC lens. And the next case, we will see the lens superior decentration. So remember, when the IC lens is superior decentration because the lens is too flat compared to the cornea. So we move the lens up half diopter or we steep the alignment curve of the lens. So here the Paragon CRT is similar. Instead of steeping the alignment curve of the lens, IC lens, Paragon use steeping the returning zone depth by 25 micrometer, equivalent to half diopter of the lens. So it's similar to the IC, it's just different in the unit. And now we see another video that the lens is low rider because it's faulting and it's too steep compared to the cornea. So the IC lens, we will flat the lens half diopter. Paragon CRT lens, we do the same. We flat the returning zone depth 525 by 500. So it's 25 micrometer flatter. So the lens will be, centration better. This is another way we can reduce the landing zone angle to make it smaller, and it will flatten the entire land. So it's very much like the IC land, but we have a two-way to troubleshooting the land. In this case, for the Paragon CRT, because we do have the landing zone angle, and we're able to correct it too. And here, there's another videos show you the land stiff fit. So with stiff fit in IC land, we flat the land. So we reduce alignment curve half diopter. With Paragon CRT, it's the same thing, but we reduce the returning zone depth by half diopter, which means we moving 525, moving down to 500 micrometer. So it's very much the same as IC land. And the good thing is with this kind of tier, we can reduce the landing zone angle, make the landing zone angle smaller, and it will flatten the entire lens down. So Paragon CRT, if we are expert, we have a many way to troubleshoot it. And here, we see a lateral decentration like I explained it to you before. With IC land, you have to find the problem of lateral decentration. It might be the size, it might be the land is too flat or too stiff, it might be wrong toricity on the lens. So in this case, we see definitely the land is too small. So with Paragon CRT or IC land, we make the land bigger, and that's all. We have other method right here to stiff the land in order to make a centration better, but it's not a critical point of the issue for the stiffing land, but the problem of this land is more likely because of the size. So the most problem is the size, so we fix it first. And then we see the land is loose fitting. And as I show you on the IC land, the land looking like this because the land is too flat compared to the cornea. So it's only touching the central cornea, but it doesn't touch the 360 degree of the land. So we only need to make the land steeper. For the IC land, we stiff the land up. We move it up to the chart. Same thing with the Paragon CRT. We'll move this number right here, 525 up to 550, 575, or 600, dependent on the degree of flattening of the lens. And there's another way for the Paragon CRT lens is to make the landing angle more, increase the landing angle to make the tier less tier to submit into the land by make the landing angle increase 1 or 2 degrees. So if from 31, we should increase into 32 or 33, make less tier in to move into the lens. So remember, Paragon CRT, we can troubleshoot it exactly like IC, but we have additional landing zone angle to fix the land and moving the land or correcting the land more effectively. And now we are coming up with a problem which we cannot do any correction before. For stiffing, flattening land, or any fitting doesn't work, then most likely it is the toricity. For example, this one, when patient blinking, the land going down, and we see a lot of tear on 6 and 12 o'clock. That means a lot of toricity, and the land doesn't have enough toricity on the eye to keeping its centration. We have to add the toricity for the land. So we increase the toricity for this eye. And here, this is when we change the toricity on the land, it have a steepened area on 6 and 12 o'clock. This area is deeper and it has the lens centration very well. And the design of the toricity is very much the same as you see on the cornea structure. So it's stiff on the line part of the color right here, 6 and 12, and it's more flat on this horizontal meridian. Well, and this is real life how Paragon Crt look like on the eye. The 9 fitting Paragon Crt, you can see a very good returning zone depth, a very good space curve, very small alignment curve, good lens movement, and lens centration itself. And it's fitting about 90% of the cornea. Well, all of these are the review that I explained to you previously. You can review at home when you have more time, similar to here and this section. Well, if you have any problem with troubleshooting the IC lens, the Paragon Crt lens, I can help you to troubleshoot remotely, but you have to provide me enough information. With this, you provide the lens code or the customized code. We have the patient name here and some of the information here. I can retrieve the lens on the system and help you to troubleshooting the lens. But before that, I need the topographer pre and post. We need the information pre and post treatment. And we also need the very good fluorescent picture and BCVA, UCVA, then I can help you to troubleshooting the lens. And don't forget the diameter of the lens. Well, so how do we successfully troubleshooting and provide treatment for autokeratology? Well, first we have to deny the contraindicator correctly, measure K correctly, because the AutoK lens is long-term use. It's very important to have a good centration on the lens. Very good and healthy tear film is so important, and it will release practitioner for later complication on the eyes. Slightly moving lens is good, and then correct or acceptable lens size is very, very important for the AutoK treatment. Practitioner should have a good team who helping practitioner in helping patient insert for insertion, removal, and cleaning the lens effectively. Practitioner have to educate client to follow up next morning, after a week, 1 week, every 3 months, and also every time when the patient have a problem with the eyes or feel irregular redness, have a tear discharge, any of the complication must contact the practitioner immediately. We have to make sure the BCVA is the best for the patient. For example, if you have the patient come into facility and have a 12 diopter with 3 diopter cylinder, and they want to partially correct the visual acuity and wear the thinner frame, then it's definitely okay for practitioner to take that case. However, instead of getting like 20, 40, and you cannot have any, you cannot correct any more vision acuity. It's not good. But if you have 20, 80, for example, but you can correct the BCVA up to 20/20. So that is better for the patient. The 8th lecture, the lecture 8 is the lecture with topographer. Will show you how to fitting, troubleshooting topographer map more effectively when we use the map mount topographer. I will show you axial map, tangential map, elevation map, and subtractive map. So for the subtractive map and axial map is the most friendly for AutoK, and Actually, the actual map is enough, but the tangential can tell you the centration of the lens on the eye better than the axial map. The MESMON is one of the effective units to be used on AutoCAD because they be well known with the GB Specialist Lab for the past 10-20 years, the past I believe 20 years, and they are very specialized for the contact lens fitting, and you can use for surgery and all other too. Well, if you provide me the information that extract or to extract from the file instead of give me a picture, then I can load into my computer and I can review exactly same as you review at your facility. So I can see the axial map, I can see the elevation map, I see the difference between the high and the low area on the cornea. I can see tangential map, how the lens is centration. I can see height, how it look like different in minus and plus number on the cornea, and because of those, I can better customize or troubleshooting the lens for you. For example, we can have the minus subtractive map on the actual power and see how the lens corrected on the eye. We can see the refractive power and see some area is very deeply refractive and all the area is less refractive to troubleshooting the lens more effective into the portion that need more refractive is the central cornea. Then we can see the centration of the lens very well by the tangential power. We can see the elevation map to see the height right here and the low area right here to troubleshooting according to the height of the cornea if needed. And then we can see the height of the cornea in general. More importantly, I can see the tear film breakup on the subtraction map. You can see the lacido ring here. It's very nicely formed. It tells you that this patient doesn't have a dry eye. But if you look into the color, you can see tear film quality is partially good in this area and very not very good, but it is acceptable on the peripheral. That means the peripheral of the lens is not very sufficiently right here, and it's caused some dryness. So we need to open more tear in this area. Overall, but if we look into the tear film surface quality, we can see good tear film on the central cornea. Very good tear film on the cornea in general, 0.049, 0.03, smaller than 0.1. So it indicates that this patient doesn't have a dry eye. Everything that approaches 0.1 unit indication for dry eye on the MESMON topographer tear film quality. And then the topographer will enable us to draw the diameter effectively. So this cornea is about 11.44 millimeter. So I will design the lens for 11 millimeter, slightly smaller than the cornea, and that's the best for the cornea. Well, there's many links here, but the above is some in Vietnamese. You can skip it because I prepared this for the Vietnamese practitioner too. And then we have the training document on my Padlet. You have a lot of information in here. And then the marketing material. Also the Paragon Crt certified information. You can click here and take the certificate for yourself. After my lecture, I believe you should be well understanding the troubleshooting for Paragon Crt, and you can get the certified from yourself. For the IC lens and Firewall lens, if you provide us your practitioner name completely, we can provide you the certificate. But for Paragon Crt, you have to get it online. And let me copy these, and then we'll paste this into the chat box, and you can have it in it. And let me see, how do I do it? All right, so did I get it? You see my chart? Okay, it's down here. So you can copy the everything from here. So well, my lecture is complete, and I am thankful for your time to be here with me. And I will pass the lecture back to Ms. Tam for continue answering your question.
Yes, so thank you, Dr. Hai, for the very informative sections. So now we will move to the Q&A sections. And now we will allow the audience to unmute themselves. And first, they need to, the audience needs to raise hands so that I will invite them to speak or directly discuss with you. And meanwhile, we have some questions here. So in the meantime, I will read the first questions. So there is Dr. Seals asked us that what are the available lens for pre-myopia?
What available lens for myopia treatment? Well, for Autocad, FDA only approved from up to 6 approved Paragon Crt up to -6. And the material is also approved up to -6 diopter. Spherical power and cylinder is 1.75. Everything above that is actually off-label. Some practitioner practitioner is actually allowed to do off-label if they think it is important for the patient. So if it is very important for the patient, they are allowed to do it. But it's also depend on the FDA of some country. Some country only approve up to -3. So you have to look into the FDA of your country in order to follow the off-label correctly.
Yeah. So what are the available lens for the pre-myopia? Pre-myopia.
For what is the available lens for pre-myopia?
P-R-E. I passed the questions on the chat box so you can see.
Could you explain this clearly? We can open the speaker for Dr. Seal to contact with me directly.
Yeah. So Dr. Seal, can you unmute yourself so that
Oh, presbyopia. I'm sorry.
Yes.
For presbyopia, we actually can correct up to well, maybe -2 and maximum -3. I'm sorry, positive 2 or positive 3. We cannot do too much on presbyopia. Thanks, Dr. Seal. Any other question? Anyone have any other question for me? You can raise your hand and unmute yourself. Hi, Dr. Hakimi. Do I pronounce your name correctly? Ms. Tam, could you unmute Dr.
Yeah, Dr. Hakimi, can you use on the left-hand side, there's the micro so that you can...
Okay, Doctor, can you hear me?
Yeah, I can hear you, sir.
Okay. Doctor, good. Thank you for your, for your lecture today. It's very good. My question is, which method you prefer, whether to fit, to give the best, to get the best fitting, whether you use the method of using the tri-lenses and then see from the fluorescent pattern, or you depend entirely on the topography. Which one you think better? Give
Okay.
the most effective one.
Yes, I follow your question, and thank you for that very good question to discuss. First, topographer is always better because we know exactly how the morphology of the cylinder to the toricity parameter exactly is the morphology of the patient curvature. So topography is the best for you to select the lens. What is your second question?
Oh, meaning that you prefer more on using the topography from the tri-lens fitting. From the
Yes, I refer topography, and I also refer fitting set, not dispense. I refer the dispensing set, not just a fitting set. When you have the dispensing set, you can troubleshooting the lens immediately, and you almost like closely to plano before you order the customized lens. So your customized lens is more effectiveness compared to not having the dispensing set on your facility.
Meaning that when it comes to to the level, to the stage when we try to customize the lens, it is more efficient to use the topography findings, right?
Yes, it's more efficient to use topography, and it's even more efficient if you use the dispensing set on your facility. You don't need to invest a very big one. You only need to invest 33 lens, 49 lens, which is very, very effectively, and for your patient in order to troubleshooting the lens or for reduce your time on exchanging the lens.
Yeah, agree that. But when it comes to topographer machines, that I have talked to some of the consultants here in Malaysia that some of the topographer, do not meet the criteria of giving the good topography finding. Do you agree with that?
Partially, I don't know the other topographers, so I don't have a
because you base it, your lecture that based on the Medmon topography.
Yeah, my lecture is based on the Medmon because I designed the land based on the Medmon. However, the other topographer to me is it's up to the experiment of the user, and it doesn't necessarily for you to have only Medmon topographer. You can have other topographer, which is fine to me. But if you have a topographer, because I use its software, it helped me better. I don't sell
possible you name a few of the other topographer that need the same as the Medmon.
Medmon is actually very especially in AutoCAD design. Most of the Medmon, topographer on the market is supplied for the surgery, and I believe any topographer that supply for the surgery is very effectively for the AutoCAD. The difference between the Medmon and the other topographer, because that we, the consultant, and we, the GD specialist lab, has been using the Medmon for many years. So we know it better than the other, but I don't mean the other topographer is not good. I can use all the topographer equally. However, I find more information for the Medmon because I has been used for more than 10 years.
Okay. Thank you, Doctor. Thank you.
Yeah, thank you, Dr. Hakimi. Do I pronounce it?
Hakimi, yeah.
Hakimi. Thank you, sir.
Okay.
I think this is another question for Dr. Yang.
Yeah, Dr. Yang, can you unmute yourself? Yeah, thank you.
Yeah, hello, hi, Doctor. Thank you so much for your presentation. It was amazing. So I'm new to Autocad, and I have a question regarding to the cell, the toric that you're talking about. Was it more like with the rule or against the rule?
Oh, most of the seal I'm talking about is with the rule. Again, the rule you're only able to correct about 1.25 diopter. Again, the rule, because the cylinder is on the vertical horizontal line, and it's very easy for the lens to be decentration. And that is the only reason why, again, the rule we cannot correct a lot, and that's all. And again, the rule, you have to have the size very big. It's maybe 85%, 95% to 98% in order to have the lens well centration on the eyes.
Oh, I see. Another question is that you mentioned about Paragon CRT is like a very easy lens to go with. And you said that it's mostly for like lower myop. So what's your recommend for like what is the highest myopia that we can go with for that lens?
Well, the highest myopia you can go with Paragon CST is -6. However, my experiment, I choose Paragon CRT for about -5 or below, because I have an IC lens, and the IC lens is better for high myopic. So everything above 5, I use IC lens.
Oh, okay. Then how high is it for the IC lens then?
Well, for off-label, we can correct up to -10, but like I say, it's up to the country that allow you to do off-label. Like USA, they allow off-label. Some Asian country, they allow off-label. Other Asian country, they are not. Some other Asian country, they only allow up to -3. So I don't know, the off-label is depend on the FDA and regulation of your local country.
Oh, okay. Thank you very much. Thank you so much.
Yeah, you're welcome. And I know that this lecture is a little bit long, so if I have a next lecture, I will break it out into small lecture. It's easier for you. But because I want a big lecture cover almost everything, it can be used for the new practitioner. So I'm sorry, the first portion of the lecture is a little bit boring.
Oh no, it's actually amazing because I'm new to Autocad lens, and this is like a good general view of what lens to go with for what patient. So that's perfect. Yeah, thank you very much.
And actually, after the lecture, I will keep the recording this video. So I will send the video back to you to review later when you have other information you need to look back.
Oh, perfect. And are you on Facebook or like Instagram so that
I'm in Facebook all the time. Not
okay.
yeah, you can look for me in Facebook. Hi, Autocad.
Okay.
Yes, and then
looking forward to your next lecture.
Thank you so much, Dr. Yang. Any other question, Dr. Chang?
No, I'm good. That's all my question for now. Thank you.
Yes, I think Dr. Hakimi have another question.
Again, Doctor, do you really recommend? I mean, for me, even for me, I'm quite new in prescribing the Autocad. That most of my early patients were those with a high power. Do you really recommend to do the Autocad for the high power, more than 6 diopter?
Like I said, it's up to your country. If your country allow off-label, we do a lot for -10. So our country allow off-label, we do a lot for -10. So -6 is not a problem. And if you use the IC lens, -6 is very easy.
Yes,
if you have
yes, effective, yes.
Very effective. And
Yeah.
if you have a -6 with a high cylinder like -3, -6 and -3, then you might consult the patient. My main job here, my main treatment here is to stop the progression of your child myopic. Your child might be freely without the glasses. in the regular day activity, but if they need something very sharp, very detailed visual, then they need very thin lens. And then many parents will okay with that if they have a very high myopic and need to be controlled and need to be reduce myopia progression. They will be okay with that decision.
Okay. Thank you, Doctor. Yeah.
You're welcome, Dr. Hakimi. Any other question?
So maybe we will wait for about 2 minutes, and I will do the ending part. Is that okay?
Yeah, sure, it's okay. Just wait for the practitioner a couple minutes for them to generate a question, or if they forget something, they can ask me now.
Yeah.
So one last question.
Sure. I'm here to answer your question.
I have been experiencing the problem with cornea staining quite a lot these days. Actually, how do you overcome that problem? Actually, cornea staining.
That is why when I teaching autokeratology, I am focusing on the reversing zone and the lens movement. If you have a very good tear film under the lens, especially the returning zone depth or reverse zone, you have a very good alignment curve, especially with IC lens. You can see the very the second alignment curve, and we have a tear under the second alignment curve. If you have a very good peripheral lens, if the lens movement very well, then most likely you will not have a problem with the cornea. And if you have a lens very stick on the eye very tight, then you can flash the lens and reduce the RX at the same time. If you look into the Firewall chart, you move the lens down and left, it will release the tear into the lens, and it will reduce the problem with the cornea, especially staining.
So means it's not really associated with the dry eye symptom first. Yeah, it's about fitting.
It is about the fitting, yes. The Autocad lens is very effectively, but if you fit it incorrectly, you will have a lot of problem with the cornea staining. Yes.
Okay, understand, sir. Thank you.
You're welcome. And pay attention to the size. If your lens is covered 100% of the cornea, you will have a problem with dry eye and staining cornea. All right, so any other question, practitioner? I'm here to answer your questions. If you have any question in your mind, please just raise your hand and we can discuss together. All right, so we wait for 2 more minutes. If there's no question, we will end the session.
So in the limit of times, we will end the webinar soon. So if you have any questions for the speaker and our products, please email us at overseas@fargo.vn, and the email is put in the chat box. And once again, thank you so much, Dr. Hai, for very informative sections. And thank you all the doctor and the practitioner to join with us today. Yeah, thank you all of you.
Thanks so much. Again, thanks for your time, and have a good night to all of you. Thank you. You can end the section. Thanks, Tim. Bye-bye. Oh, we have another question from Dr. Ying. Miss Tim?
Yeah, so Dr. Ying, can you unmute yourself? Hello, Dr. Ying.
Thank you, everyone. Thank you.
So I will end the webinar. Is that okay?
Yes, please.
Yeah, thank you.
Thanks. Bye-bye now.
Yeah.
See you in the next session.
Yeah.
And don't forget to recording the section, please, Tammy and Jang.